Hi guys, Jack Wickstead from Beth Israel in Boston. So pleased to be with you today. I just wanted to uh, show you where we are here in Boston. Just had a big snowstorm. Hopefully you can see this. A little bit of snow there. Far away from where you guys are. Anyway, wanted to show you a little bit of snow. Hopefully that came through on the video. All right, I'm going to switch over to my desktop here. Okay, so today's topic, we're going to talk about distal docking site issues for Elizabeth bone transports. I'm going to try and speak slowly. Hopefully, I don't get too far out of hand. And I'm going to try and keep this fairly simple and a little bit practical. There's a lot to learn on bone transports and Elizarov frames, and it can be a little bit overwhelming. Um, Most of what I've learned, I've just learned by doing these over time, much like many of you are doing. So stick with it. You'll learn a lot as you go along. It's really not that complicated. And the things that we're going to talk about today are one of those real problems that we have with the Lizarovs that we all have to kind of struggle through to figure out what works best for us. Okay, so let me just switch to the next slide. There. So here's our objectives for today. We're just going to talk about some common complications of the docking site after a bone transport. We're going to talk about some strategies for overcoming these issues. And I'm going to talk a little bit about why I tend to use intermedullary nails after a transport. They work well for long bones, work well for the tibia, work well for the femur, and they can have a couple of very helpful benefits. Specifically, they can really facilitate your docking, and they can also shorten your time in the frame. Okay, so we'll start with a case. All orthopedic surgeons love cases. So we're going to start with this is a fairly straightforward situation. This is a 27-year-old guy who came to see me, had a gunshot wound in June of 2024, and came to see me in November. In June, he had initially been put into an external fixator, as you see here. His fibula had healed, but he had been left with this big bone defect. This was because they just didn't have any soft tissue coverage options for him. So they treated him with wet to dry dressing changes, no further treatment, and they told him that they were just waiting for him to granulate in fully before they would do any further surgery on him. Um, in talking with him, it sounds like they were planning on doing a bone transport, but they were waiting for his wound to fully granulate in first. A challenging patient here. He weighed over 300 pounds, BMI over 41, and was smoking half a pack a day. So long conversation with him and his mom about smoking, and his mom laid into him and got him to quit. So he did actually quit smoking about 2 weeks before our surgery. So that's a good for him. Now, when we look at his total defect here, he has really about a 15 centimeter full defect. In addition to that, he's got about a 2.5 centimeter leg length discrepancy. And we'll talk about the leg length discrepancy and how we might address this down the road. So really a challenging defect here, quite a big hole. But the biggest thing that I worry about with these patients really isn't the size or the amount of the bone defect, or really anything to do with the bone itself. The bone is pretty easy to deal with. The biggest complication we really have is infections and bad soft tissue defects. And you can't really do bone transports until you've handled his soft tissue defects. Now, he had old granulation tissue in here, colonized with all sorts of stuff. Excuse me just for one sec. Sorry, technical issues. I realized I had um, put a picture of the case in here, but it wasn't showing up. Anyway, here we go. We'll go forward to the next slide. So here's the soft tissue defect that we're looking at here. You can see this is fairly sizable, got some granulation tissue here in the base. Overall, it looks quite clean, and I think the care that he was actually getting in Puerto Rico was quite good, given that they couldn't put a flap on him. Now, I am reluctant to transport through just plain granulation tissue like this. I think if you were going to do this, you'd have to freshen that up and put a skin graft over it and really get, better coverage than he has if you were going to do this without a flap. Fortunately for me, I have good access to plastic surgery. For me, this is a flap, 10 out of 10 times. But again, that can be really challenging in resource uh, in resource challenged settings. It requires microsurgery. It requires somebody with some experience. In this case, we did a gracilis flap and a split thickness skin graft. But again, this isn't terrible. You could freshen this up and put a split thickness skin graft over the granulation tissue and probably get that to heal and then try and do your bone transport, without the flap. But again, that's a multi-month process of getting that defect to heal. In our case, we opened this up. We debrided this all out. We took a lot of cultures, and fortunately, all the cultures came back negative. So he had been treated with a course of antibiotics early on when they started to do his dressing changes. And yeah, so he wasn't infected. That really helped us. So after we got this all debrided out and covered with a flap, then I can actually, start to work on the frame. You can see I've got the top ring of the frame, which I attach first with just a single half pin, and then I added two additional half pins for further stability on that top frame, trying to keep that as parallel to the joint line as I can. And again, in similar fashion, I have three half pins in the distal segment. That red circle there, that's the gracilis flap that we put in. So that's inset underneath the skin margin and then covered with a split thickness skin graft. So really not a complicated frame here. I got three half pins at the top. I got three half pins at the bottom. I've got this ring here in the middle, which is my transport ring, right? I'm going to use this thing for transport. So it's not actually attached to the rods here. It's just free floating. And I'm just going to do a simple elevator transport here. So you can see here, I've just attached that transport ring with a single half pin to my intended segment, and I'm going to osteotomize him here, and then use this bottom piece here for the transport segment. Now, I'm not going to do that right away. I'm not in a big hurry. Um, I want that flap to settle down. These flaps have to really take well and make sure that there's no, problems with the flap regressing, that the skin graft has all healed up nicely. So I'm going to let him sit in that frame for 2 or 3 weeks until myself and my plastic surgeon are certain that his soft tissues are well covered. And once I'm sure that there's no flap tissues, I can just bring him back for a little day surgery procedure. And you can see there where I've done the osteotomy. Here's what he looks like. You can see I've done the osteotomy right here. So I've got my transport segment really only attached with one ring. I think you could easily put a second pin in here if you wanted to. I thought we could transport him probably with just a single ring. Um, and I'm going to be using these clickers, which make it easy for him. And I can, use these to bring it down. But you can use standard Alizaroff rods for this, or screws along the Alizaroff rods here, which work just as well. So, I have these. They're nice, but again, simple nuts and bolts on the Alizaroff rings will also work for what is a pretty straightforward elevator transport. And here he is going through his transport. Our talk today really on docking sites, so I'm going to skip through all of this. But you can see here we are in February, and there we are in May, and we're starting to get close, but we got a long ways to go here. And that would be my first tip for docking. Once you've had the patient in the frame for 3 or 4 months, he's getting anxious, you're getting anxious. Don't get impatient on these things. You really need to make sure that if you're going to have a successful docking, that you've really transported sufficiently. Don't try and cut any corners at the end. It's easy to get impatient and to think like, okay, I'm pretty close now. I can do my docking. Don't. Make sure that you've got this thing really sufficiently transported. Um, I would say also, focus on what you're doing here, which is the bone transport and filling in that defect and getting your tibia healed. I'm not really worried about my leg length issues here. If you recall, this patient had a 15 centimeter defect and another 2.5 centimeter leg length discrepancy. That's a lot of transport. And if I'm going to really address his leg length discrepancy, I'm going to have to osteotomize his fibula, which I really don't want to do if I don't have to. So I'm going to leave his leg length discrepancy to fight for another day. A healed tibia that's short is still way better than a big bone defect. And once he's healed down the road, I can always deal with his leg lengths. So right now, I'm just worried about the bone transport, not going to deal with the leg length discrepancy. So he really needed at least another 2.5 centimeters here. So I kept going with my bone transport. And then eventually I got to this position. And here I was pretty happy because I'm overlapped a little bit here on the AP. So it looks like I've gone actually too far, but that's not really the case. What this is going to do is allow me some bone apposition between my transport segment and my distal docking site. So, this is a sort of triangular shaped piece of bone. This isn't a nice cut off, squared off piece of bone. A lot of folks will like to cut off, that segment and give themselves a nice flat surface here and a nice flat surface here. I'm perfectly happy with something like this as long as I can get good bone apposition between my transport segment and my docking segment. And here I know, look, I'm axially off, but I know I can get good bone apposition there. Um, this is a nice article here that looks at docking site complications. This is open source article. So if you're looking for, a quick survey on this, you can get this PDF online for free. This looked at 103 patients. It's a recent paper from 2023. And this were the complications that they have. These are the complications we all have. Delayed union of about 20%, axial deviation almost another 20%, and problems with soft tissue incarceration about 10%. So overall rates here, approaching 50% on docking sites. These can be really challenging, but if you just take them one at a time, you'll do just fine. The risk factors for these problems really for delayed union was long segments and long transport times. No surprise here. Also risk factors in the distal third of the tibia. Also no surprise. Periosteum is really pretty poor in the distal third of the tibia. We know dealing with pilon fractures and distal third tibia fractures, those can be really challenging to get to heal. So no surprises here. Long segments, long transport times, high risk of delayed union. So when I'm dealing with these, risks of delayed union and I'm worried about the docking site, I'm perfectly happy to use iliac crest bone graft and I'll use it whenever I think I need to. But number one, what I really want to make sure is that I've got good, decent bone apposition at my docking site. And by that, I mean that the transport segment and the distal segment are nicely locked together and I've got a good segment of bone right in contact with bone. Don't forget this regenerate that you've just created. You've spent 3 or 4 months making this regenerate. It will act like a spring. And as soon as you take off the frame, that regenerate segment, boing, is going to want to return right back to where it started from. So these things can very easily pull apart. And I will put a plate on each one of these. Now, you don't need a giant plate. If you're going to avoid delayed union, you really need to get that bone opposed. Once I've got the transport piece where I want it and I'm happy with it, I'm going to let everything settle for a little bit. In this case, I let it settle for about a month. I think that makes my regenerate a little more mature. I think it makes my transport segment a little more likely to stay where it belongs and a little less likely to spring apart. It gets kind of used to being in the position where it belongs. And then I will open up that site and I will put a little small plate on that thing. Now, you have to be careful when you put this thing in. You can't just treat this bone, poorly and take a Cobb elevator and scrape it all off. That piece is alive and you really want to keep that thing alive. So I'm teasing that kind of back into position. I might make a couple of little small drill holes, one small drill hole in the transport segment, one small drill hole in the distal segment, and then, put them in such an angle that I can get a pointed tenaculum in there and just pull those two pieces together. And if I can pull them together and get good, decent bone apposition, then I'll put a little small plate on here. You can see this is just a little mini frag plate. I've used two little unicortical locking screws on that thing, and it just stops that piece from pulling apart and maintains as much bone contact as possible. And this also allows you to correct our next biggest problem. If you remember back to our complications, the first one we're going to deal with is delayed union. The second one is going to be axial malalignment. And you can see this is on my AP. As I brought that segment down, there was a fair degree of axial malalignment here. Um, Oftentimes your causes of axial malalignment are usually related to, inadequate stability of the transport segment. Now, in this case, I only put one pin in there, but I watched them pretty carefully. And if I had started to see my piece start to deviate, then I would have certainly brought him back to the operating room and added another pin. Um, the Actually, the most common cause really of axial malalignment is soft tissue entrapment. You've got soft tissue opposed between your transport segment and your docking site, and there's soft tissue in the middle, and you're trying to force that transport segment towards the docking site, but the soft tissue won't let you. And as a result, that transport segment starts to deviate. As soon as you recognize that, you've got to stop what you're doing, go in there and excise out that soft tissue entrapment. So, in this paper, they've listed axial malalignment as a separate complication related to soft tissue entrapment. In my experience, most of the axial malalignments are related to soft tissue entrapments. This is another nice paper that you can get online for free. The PDF is online, um, fairly recent, 2010, but it's a nice overview of the sort of principles of deformity correction that you can use the Elizarov for. A nice little review article you might want to look at. How do they recommend dealing with this kind of problem? If you get progressive deformities, you might have to add some more pins. You can certainly go back in, free up um, your pin from the transport segment, add another pin to it, and add some stability. That may help. But usually, what you've got is an issue of soft tissue interposition, and that usually needs some resection. I would suggest that if you are, getting towards docking and you're realizing that you're getting some axial alignment, that you stop, and you can excise that tissue out. One good way to avoid this whole problem of soft tissue interposition is to get smart at the beginning. If I have a patient with a fairly sizable defect and I'm worried about them being infected, I will open it all up and to breed them all out and clean it all up and get some deep cultures. And I'm perfectly happy to put a cement spacer in that block and then put my frame on and let them settle down until I'm happy with my soft tissues. Then, when I'm ready to do my transport, I can take that block out. And that block is now acting as a nice channel for my transport segment to slide down. And this I've found really minimizes my problems with any soft tissue interposition. So I try and do this in stages. In this, particular case that we're talking about, we did open them up and debrided it all out. I didn't use a cement spacer, but we certainly had a channel, that we created from our debridement. I'm perfectly happy to put a cement spacer in there and then take it out. It only has to stay in there for 2, 3 weeks. You're not trying to induce a membrane here to help you heal. You're just trying to give a mechanical, pathway for that bone transport to drive down. So let your wound settle down. If you are in the situation where you're excising some soft tissue, excise it all. Let your wound settle down for a little bit. Hold on the transport for maybe 10 days or 2 weeks, and then restart your transport. It's not going to be solid enough that you can't then retransport it. And now, because you've removed your soft tissues, you can get that transport segment to dock down back where you want it to. So back to my patient. I took him back to the operating room about a month after I finished his transport, and I put this nail in here. I used to be pretty cautious about taking the frame off and giving the patient a pin tracked holiday and then putting the frame on. And certainly this would be a good case for that. If the pins are actually in pretty good condition and I don't see any overt signs of infection, then I would say probably at least 3/4 of the time I will just, nail the patient right away. I like putting a nail in. It helps the regenerate. It gets the patient out of the frame earlier. It gets everybody bearing weight on this thing better. And it corrects any issues that I have with axial malalignment. I can use my small plate to anchor my transport segment, and then the nail itself is going to be very helpful for me maintaining overall axial alignment. This is this is him at 9 months. Didn't bone graft that site. Didn't think we needed to. Had good bone apposition from the beginning, and everything came together actually pretty nicely for him. So here he is at 9 months. So just by way of conclusion, distal docking site, number one, make sure that you're doing a long enough transport segment. If your segment is too short and you can't get that bone to lock together, you're going to have a problem. So get some decent bone apposition. Once you get good bone apposition, again, a couple of small drill holes and pulling it together until it locks into a nice position for you, and then using a mini frag plate to hold it in place so it won't spring open is a reasonable way to go about that. I've had plenty of these where I've been able to sneak a lag screw around it as well, and that can be helpful. But again, a mini frag plate is not a lot of soft tissue dissection to get it in. It usually fits pretty well underneath your soft tissues, and if you keep it flat to the bone, it's not very prominent. Just be careful with your soft tissue handling in this. You can't tromp around in there. You have to do it gently. I like to trade my frame for a nail. My patients, don't like the frames. Heck, I don't like the frames. They're great for doing bone transports, but they're a lot of work and they're really, a big burden for the patient. So the sooner I can get them out of their frame, the happier they are. And so, once I've got my bone transport done, once I've plated my bone transport into place, I let them settle for a few weeks, and then I'll take the frame off and exchange it for a nail. And that will usually correct my axial deviation problems as well. Any problems I have at the distal docking site will be handled. A nice mini frag unicortical locking screws won't get in the way of my eventual nail. So I'm putting that plate on with the intention of coming back and putting a nail on in a few weeks. I do this in stages. You can tell this is sort of, you've got to think a few steps ahead here. And, I'm perfectly happy. I tell the patients, look, if we're going to embark upon this journey of bone transport, this is going to be a series of operations for you over the course of, 6 months or so for us to get through this. So if I have to, spend one operation getting the bone transport pinned into place where I want it with a little small plate, and then bring them back 2 weeks later, take the frame off and nail them, I'm perfectly happy to do that. So, by way of stages, my first goal really is to get rid of the infection. Cement blocks can be helpful for that. Then you just take them out. It makes a nice channel for you, and then you can start working on the rest of it. And then lastly, just as a final note, this is my patient here. He's quite happy. He's 9 months out. He's out of his frame. He's walking on his leg. He didn't get an amputation. He's pretty happy with this. I did not try and address the leg length discrepancy at the same time. You certainly could. You could osteotomize the fibula. You could try and add some more length to this. I am perfectly happy to get a nice double. We have got his bone back into one piece. His tibia is going to heal. He's not infected. He can walk. Yes, he still has his 2.5 centimeter leg length discrepancy. That's a relatively straightforward thing for me to fix down the road. I can lengthen him again through the proximal third of his tibia as a straightforward leg length discrepancy. Yes, it's two procedures for him over a longer period of time, but it's safe. I'm not, trying to hit home runs here. I'm trying to do things that are safe for the patient. Every time you try and stretch a double into a triple, you might get thrown out. So again, I'm perfectly happy to address the problem that's in front of me, the leg length discrepancy, and I'll fight the problem that's in front of me, which is the bone defect. I'll fight his leg length discrepancy as a separate procedure. I think I think it's safe. Okay, thanks, guys. Really appreciate your time.